In my opinion, the vast majority of people with chronic low back pain would benefit, for example, from physical therapy. But it's a pretty small minority of patients that actually see a physical therapist. And even though the guidelines say we should be emphasizing, exercise-based therapies and things like that, the problem is that there's a lot of barriers for primary care physicians to do that. It's much easier to order an imaging test. It's much order to give a prescription for an opioid, and it's even easier to refer somebody to a surgeon.
Today we have the privilege of welcoming Dr. Roger Chou, a powerhouse in the world of evidence-based medicine. As a professor at Oregon Health and Science University, Dr. Chou has dedicated his career to shaping clinical guidelines and standards, particularly in the complex areas of chronic pain, opioid use, and addiction. With over 300 peer-reviewed articles and his systematic reviews cited globally, Dr. Chou's work has influenced organizations like the CDC, the World Health Organization, and the American College of Physicians. In this conversation we're about to have, we dive into his insights on translating data into meaningful clinical practice and how his research has guided some of today's most pressing healthcare decisions. Don't move. This is Hands On, Hands Off. Roger, welcome to the show.
Thanks for having me.
For people listening, what's your sort of superhero backstory? How do you explain when someone at one of these mixer events says, "Hey, tell me about you"? How do you typically answer?
Well, I'm not a physical therapist,
right?
So I'm a physician. I've done a lot of work in low back pain. I started working on this around 20 years ago. I developed one of the first national guidelines for the American Pain Society and the American College of Physicians. Just looking at the evidence, and that's just kind of snowballed from there. So I've worked on a number of different guidelines for low back pain, pain in general, addiction, some other areas. It was kind of eye-opening because when I started looking at the evidence, a lot of it didn't really match what people were doing, and a lot of that's gotten into the guidelines. So I think things have changed over the last 15 years or so.
Yeah. Well, you're speaking here this weekend at AOMT. What are some of the big take-home messages? You can tell me. I'm not going to tell anybody. We'll keep it between us. But what are some of the big take-home messages that you hope the people here and outside the conference can really latch on to?
Yeah, well, first, I'm very pleased to be invited to a conference like this. Like I said, I'm not a physical therapist. I think back pain in particular is a condition that really benefits from a multidisciplinary perspective, and so I really do enjoy coming to places like this. I think what we found when we looked at this was that there was a big disconnect between what was happening in practice and what kinds of benefits people were seeing. So what I mean is that we had data showing very marked increase in use of imaging for back pain, in use of surgery, in use of injections and other interventional procedures, and use of opioids. But at the same time, we were seeing that we actually had more back pain than before, that the back pain rates had actually doubled, despite all this money and all these procedures. And I think what we've come to understand is that back pain cannot be approached as a simple, biological or mechanical issue, that it's a complex biopsychosocial problem.
Sure.
And that we need to focus a lot more on restoring function,
Sure.
addressing the psychosocial contributors to pain, really focusing much more on the non-pharmacological therapies, including exercise therapy, mindfulness-based strategies, cognitive behavioral therapy, really kind of shifting our approach and not using, so much imaging and so many surgeries and opioids and things like that, which really are not more effective and in many cases maybe less effective than maybe these other approaches.
You mentioned shifting an approach. You've been part of developing the clinical guidelines for challenging areas like what we've just been talking about, chronic low back pain. What are the biggest hurdles when it comes to translating complex data, the evidence, into actionable guidelines for clinicians and actually having them follow those guidelines? What are the biggest hurdles? What are the things we need to overcome?
I think there's a lot of issues. One, there are a lot of systems issues, and so it's easier for somebody. In my opinion, the vast majority of people with chronic low back pain would benefit, for example, from physical therapy. But it's a pretty small minority of patients that actually see a physical therapist. And even though the guidelines say we should be emphasizing, exercise-based therapies and things like that. And the problem is that there's a lot of barriers for primary care physicians to do that. It's much easier to order an imaging test.
Sure.
It's much order to give a prescription for an opioid. And it's even easier to refer somebody to a surgeon. You can do my health system uses Epic, and you can do a referral in Epic very easily to a surgeon. Whereas, for physical therapists, most primary care docs don't know the physical therapists in the community.
Wow.
Most of the time, they're telling patients to go find a physical therapist because there's no real referral mechanism.
Wow.
Or it's outside of insurance, or the patient needs to figure out who their insurance will cover. So there's those kinds of barriers that it's hard from a primary care perspective to do it. I think that there are patient expectations. People expect to have an imaging test ordered or to get a prescription. And they may resist when somebody tells them maybe you should go see a physical therapist or go see a psychologist. There's payment reimbursement issues. There's convenience factors that patients, may not all be able to take a half day off work to go see a physical therapist once or twice a week, or they may have childcare issues, or there's other, barriers. And, so I think there really do need to be, creative ways to think about how to incorporate and integrate these types of therapies, make it more streamlined, seamless in terms of how to, engage these other types of professionals and other services. Until it's as easy to refer somebody to PT as it is to write a prescription for an opioid, and we're probably still going to have, a lot more opioid prescriptions.
So it feels like there's more things to change on our side than there is on the patient's side.
There are, and I think my experience has been that if you explain to patients, why you're referring and what kinds of benefits you're expecting to see, I think some patients may have the perception that if you're not referring them to the surgeon or doing an MRI, that you're not taking their pain seriously.
Sure.
And so you do need to take time to explain what you're doing and the reasoning why. You do need to build that trust. So there's all sorts of, factors and barriers there, but I do think we can do a better job.
Yeah. Your systematic reviews that you've worked on have really helped to, shape guidelines worldwide. I don't think I'm overstating that.
Yeah.
Walk us through the process of actually conducting a systematic review that impacts something as high stakes as low back pain. You've also worked in areas like addiction and chronic pain management.
Yeah, it's a long process. Doing a systematic review is kind of its own discipline and requires, its own expertise and a lot of man hours. Right now it involves, there's many steps to the process. The first step is, defining the topic and figuring out which questions you need to ask, which can be answered by doing a systematic review. That will enable a group to make recommendations, and then you go through the whole process where you search for the studies, figure out which ones meet your inclusion criteria, abstract all the data from them, assess their quality, and then oftentimes we'll do a meta-analysis, so we'll pool the data and then trying to put it all together in a way that makes sense to people. But the idea is to be systematic and comprehensive and to be unbiased, and so the old way of doing guidelines was for people to sit around a table and, whoever spoke the loudest or whoever had, waved, the particular paper around, would kind of win the day. But
sure.
With the idea with systematic reviews is that you have a rigorous process that's reproducible and transparent, and comprehensive. You're not cherry picking any evidence. You're using all of the data. You're considering the quality, and then you're trying to put it all into context for the guideline development group.
Yeah. Rapid evolution in medical research, right? Things seem to move faster and faster. How do you make sure that the guidelines stay current for practical, real-world clinical applications? How can you make sure that the thing that you're doing in research is actually going to be applicable in a clinic or in a setting?
Yeah, it's tough because it's actually exponential in the amount of research that's being published. So it keeps getting more and more, and it's accelerating. We saw this actually with COVID, where it was a tremendous amount of evidence that was just snowballing from month to month. And we do see that in all areas, that there's just more literature being published. So, we do have an updating process, so we can update, every 3 or 6 or 12 months, depending on, the urgency of the issue, how much new evidence is being published, whether there's important new studies, those kinds of factors. In some cases, we do what we call a living review approach, which is where we essentially continuously run searches and update the results as new studies come in. This can be time intensive, but can be very important. So we actually did a number of systematic reviews during COVID for the World Health Organization and other groups, where we were doing a living review process, where we were essentially updating them every week. There is, I think the future is going to be use of machine learning and artificial intelligence. I mean, we're going to have to use those technologies to make the process more efficient and faster, but we also have to be sure that we understand, what we can use machine, when we can trust it and what processes we can use it for.
Yeah. Last thing we've been doing with each guest is asking for a parting shot. So if there's one idea or one sentiment that you'd want to leave with the audience, maybe something that you'll be talking about on stage, what's the one thing you'd want to leave as people go forward as we wrap up?
Yeah, that's hard. I guess I would say that, from my perspective, the role of physical therapists is critical for effective management of low back pain, and just the idea that we need to figure out how to, seamlessly coordinate, what the physicians and the physical therapists are doing. That's what's going to benefit our patients. Sounds great.
Hey, I appreciate you coming here to bring an outside viewpoint, both in research and coming from outside of the PT profession to come help physical therapists here at AAOM 2024 understand a little bit more.
Yeah, great. Thanks for having me.